Hi, I'm Ernie, and I'll be going through the treatment localization, verification, and delivery for 3 different cases. We'll be looking at SABR to the left lower lobe long, a left breast with simultaneous integrated boost, and a prostate and seminal vesicles case with a hydrogel spacer. We're starting out with our first patient in her late 70s presenting with a whole performance status of 2, and she has a T2N0M0 non-small cell lung cancer and a peripherally located tumor in her left lower lobe outside of the central zone, which includes the spinal cord, the heart, the trachea, the esophagus, and the major vessels. It is deemed a peripheral tumor as it's located more than 2 centimeters away from the proximal bronchial tree and central structures. According to current guidelines, the GTV constitutes the visible lung tumor delineated with the guidance of MRI or PET and CT fusion. The CTV is the motion-adapted GTV with no margin for microscopic disease extension. The internal targeted volume, according to the ICRU Report 62, compromises of the GTV in all phases of the respiratory cycle, and a 5 mm margin is added to the CTV to make the PTV volume to account for inter- and intrafraction motion. For our patient position, she is laid head first supine on a wingboard with her arms raised and bringing it away from the treatment field. She has a customizable backpack, and it was utilized for this as she had trouble lowering her arms upon the board, and it has also helped to improve the comfort for maintaining the position for a lengthened period of time. The knee fix and the prostate are also utilized to minimize the rotation of the lower abdomen. Since it's a lower lobe tumor, it is subjected to diaphragmatic motion. Breathing-induced motion influences the position of the tumor and organs at risk, which may result in geographical miss and lead to a potential tumor recurrence and an extremely high dose to the healthy tissues, and later on, potential radiation-induced toxicities. Therefore, motion management techniques, which includes abdominal compression. This patient had her tumor motion was more than a centimeter on her day 0 for the CBCT. Therefore, the clinicians and the physicists incorporated the use of a compression arc and paddle that is indexed onto the compression board placed on top of the treatment couch. It is made out of carbon fiber, so there's no attenuation to the radiation beam, thereby minimizing the effect to the dose distribution. When we set the patient up, we feel for her SSN, the suprasternal notch, and the Zephyr process, utilizing the anterior laser to align the midline to ensure the patient is nice and straight. We then align the lasers to the indicators at the compression board, which runs in line with her lateral tattoos as we rotate the patient accordingly, and her medial tattoo was helped to move to the isocenter. The patient is then also asked to take quick and shallow breaths before the pedal is lowered and pushed down to limit diaphragm motion. We also have marked the block as we are using respiratory gating. We have the breathing block with infrared markers and the infrared camera to monitor her breathing pattern throughout the treatment. As we are delivering such high ablative doses, high-quality IGRT and verifications are imperative in ensuring treatment accuracy. We first use a 3-point ID check, which includes the patient name, their date of birth, and the first line of address before every treatment to ensure that we got the right person in. When we move our shifts from the isocenter in the room, we ensure that the values are read back and verified with measurements with a ruler. We also record the anterior and lateral SSD and ensure that they are within a centimeter tolerance. According to departmental protocol and on-target 2 guidance, a 40 kV CBCT scan is performed on day 0 for this patient due to the influence of the respiratory motion for the location of this tumor. A physicist was also present, and they were there to ensure that there's adequate ITV coverage of the tumor in all respiratory cycle, and to determine whether margins will need to be extended. We also took note on whether the patient will be able to maintain the position throughout treatment. Then on her first day, we then proceeded with a 3D CBCT as we had implemented the use of abdominal compression. Before performing the first KV CBCT, we confirmed that we have the right patient on the bed once more, and the fractionation that she is on, and the anatomical site of imaging. We monitor her amplitude of breathing against what was recorded at CT to ensure that it is within threshold. And once the scan is taken, an auto match with bone and rotation is included for a quick gross error check, and this to ensure that the patient is set up appropriately. If it's equal or more than a three angle difference on rotation, we'll go back into the room to reset up the patient. If you're happy with the setup, we then record the values and untick the box for the rotation, and we perform our soft tissue match, checking the tumor coverage on all slices, making sure that it is within the target volumes. And there's a very tight tolerance of 0.3, and we will then apply the shifts as well. Before we deliver the first treatment field, we will then perform a verbal verification. It's a very high dose. We will verify the patient's full name, the monitor units for each field, the energy, the collimators and gantry angles, and the X and Y jaws involved. We will then proceed with delivering the treatment for the first field. Once the first field is done, on our first day, we will perform a mid-scan for all of our SABR patients just to ensure that there's no significant movement by the patient in between treatment. Repeat the same actions. We perform an auto match and then a soft tissue match, applying shifts where it's necessary, and we perform our verbal verification once more before we deliver the second field. And once we deliver our second field, we will then perform our post-CBCT scan. This is not implemented in all the different departments, but we do perform one for the physics checks and QA. So if a patient were to cough during treatment, for example, physics could take a look at it and determine whether they will need a dose compensation for the next fraction. If there's 0.2 centimeter shifts in two different directions or more than 0.3 centimeter shifts in one direction, we are then also more inclined to perform a mid-scan for the next fraction as well. We'll now look at the treatment delivery for our patient receiving SABR. We utilize the volumetric modulated arc therapy with two partial arcs rotating clockwise and counterclockwise with angles from 179 to 325 degrees to avoid the contralateral long. Dynamic MLCs tracking with widths of 5 to 10 millimeter are used to conform the beam to the target while the gantry is rotating. The location of the tumor determines the dose and fractionation, with PTV not abutting the chest wall receiving 54 gray in 3 fraction, while PTV abutting or overlapping chest wall receiving 55 gray in 5 fraction, and all centrally located tumor receiving 60 gray in 8 fraction. Long-term results from the RTOG-0236 trial investigating the outcome in delivering 54 gray in 3 fractions for peripherally located T1 to T2 non-small cell lung cancer had survival rate of 40% at 5 years and has high tumor control rates compared to conventionally fractionated radiotherapy. The plan is optimized using dose volumes constraints from recommendation from the UK SABR Consortium guidelines and RTOG protocols, where the PTV is homogeneously covered with 95% of it receiving 100% of the prescription dose. And ideally that there's a steep dose fall-off, that 50% of the isodose does not extend further than 2 to 3 centimeters from the PTV. This is also to ensure that the organs at risk are spared from radiation-induced damage to obtain a favorable therapeutic ratio between treatment benefits and morbidity. A 3 millimeter planning risk volume is applied to organs at risk as well. One of the dose constraints for the organs at risk involves the percentage of lung volume receiving 20 gray. It is a metric considered to minimize the risk of radiation-induced pneumonitis. The risk is reduced to 0 when the V20 is kept below 22%, so that compromises approximately about 1/5 of the total lung volume. A 3 millimeter planning risk volume is applied to organs at risk as well. One of the dose constraints for the organs at risk involves the percentage of lung volume receiving 20 gray. It is a metric considered to minimize the risk of radiation-induced pneumonitis. The risk is reduced to 0 when the V20 is kept below 22%, so that compromises approximately about 1/5 of the total lung volume. We will be delivering this treatment on alternate days with a minimum of 24 hours in between. The principles in utilizing fractionated radiotherapy stem within the radiobiological factors, as time intervals between the radiation doses allow for the normal tissues to recover and to repair the radiation-induced damage. The time frame also allows reoxygenation to occur, kind of mitigate the adverse effects of hypoxia, and to reduce the proportion of radioresistant hypoxic tumor cells by the end of treatment. It also allows the redistribution of cells across the various cell cycle phases and allows the elimination of cells in a more radiosensitive stage of the cycle. Backup gating is also used. The treatment is only delivered when the patient is in a specific respiratory threshold, and the beam will automatically shut off when she's not. Therefore, when performing the CBCT scan, radiographers will have to be mindful of holding the beam while the patient is not within the threshold, as there's no backup gating on that particular scan. And we'll end this case here. For our next case, we are looking at adjuvant radiotherapy to the whole of the left breast for a patient who had underwent a lumpectomy and a sentinel lymph node biopsy. Her histopathological examination concluded that she has grade 3 invasive ductal carcinoma with DCIS components, and she has no nodes involved. According to NICE guidelines and the RCR consensus statement, given her age, which is below 50, and her high grade, she will be entitled to receive a boost to her tumor bed, as the lumpectomy cavity and surrounding region is known to be a high-risk area for tumor recurrence. As we move on to our target volumes, it is a field-based PTV for our whole breast, which is helped denoted by our anatomical borders. And the clinical target volume for the tumor bed is outlined by drawing around the implanted surgical marks and any changes in the surrounding tissue. A 5 mm margin is added to obtain the PTV for the tumor bed. For our patient positioning, she will be laying head first supine on an inclined breastboard, which is to help acquire the parallelity of the sternum to the treatment couch to obtain an even lung volume for better dose homogeneity. She will have both of her arms up with the right one over the left, gripping onto poles and resting them into arm cups to move them away from the treatment field, and to also just help slightly raise the breast tissue to try and minimize the skin reaction at the inframammary fold. The arm, lumbar, and footboard rests are all adjusted for the patient's comfort to help aid reproducibility. She has 2 lateral tattoos which are also in line with the breastboard, and this helps us rotate her accordingly when we set her tattoos up against the lasers. And she has 1 medial tattoo which we can then apply the shifts to move to the isocenter. As we are treating her left breast, the patient will be involuntary deep inspiration breath hold, and we use a real-time position management visual feedback system, which includes the use of a breathing block with reflective infrared markers, and we have infrared cameras as well to help us monitor the patient's breathing pattern throughout treatment. And this patient also has a monitor which allows her to see her own respiratory cycle, and there's a threshold bar from the pre-treatment scan, which helps her indicate the amount of inhalation required. As this patient has larger pendulous breasts, she did experience erythema and dry desquamation towards the end of her treatment, especially in her inframammary fold. Prone positioning can be a consideration as gravity pulls the breast away from the chest wall, and this helps reduce the deep skin folds. Research has also shown decreased volume of lung within the treatment field and a reduced cardiac dose for patients who can tolerate prone position and DIBH. Optical surface-guided radiotherapy is also another consideration, as it has shown to be beneficial for patient positioning and monitoring throughout the treatment fractions, and it can also help detect the anatomical variation throughout the treatment course. The surface-guided correction of the patient posture, the arm, and the chin position also helps improve the position of the breast in general. As optical surface scanners utilizes the patient's skin, tattoo-free radiotherapy workflow can be utilized, thereby mitigating the potential psychological impact of radiotherapy tattoos to the patient without sacrificing the treatment accuracy. As we look into the treatment verification for this patient, we use a 3-point ID check before every treatment to ensure we have the right patient on the bed. And as this patient is within the fertility age, from the age range of 12 to 55, we have to ensure that she is not in the possibility of being pregnant, as high radiation exposure has detrimental effect to the fetus. On the very first day, a breast radiographer will also be in the room to ensure that everything is falling within tolerance and applying troubleshooting measures accordingly. On setup, we first get the patient to relax nice and straight onto the bed, and we align the lasers to the breast spot value and her tattoos. We then verify the SSD value located in of the medial tattoo when the patient is in breath hold and that it is in total of 1 centimeter before we apply the shift. We then verify the calculated shifts with a ruler, and we also ensure that there's no collision risk with the patient's arm and the start and the end of the gantry angles of the integrated boost fields, so we could add automation when we are delivering treatment. For both fields, we check the SSD, which has a tolerance of 1 centimeter, and how the field light is falling in relation to the tattoo. And we check the field coverage against the secondary capture image and to ensure that the inferior edge of the breast is still falling within the field. Before we switch on, we ensure that we have the right person on the bed once more by confirming the patient's name and fractionation that will be taken that day on the system, and we will make sure that her breathing is within the threshold, that it is steady and not being too erratic, shallow, or inconsistent. We then coach the patient to be in breath hold, and we perform our daily orthogonal kilovoltage pair imaging. The KV-KV pair provides us with better bony anatomy definition when compared with a 3D CBCT. We perform a 2D image match to the tumor clips using the appropriate content filter to help us visualize the clips better, and we will try to achieve the best fit to ensure the contour are touching most of the clips. We can also check the lung volume and to ensure that it is not exceeding of 0.5. We also use our chest wall and the ribs to ensure that we are at the right vertebral levels. According to departmental protocol, there's a greater tolerance than the standard 0.5 as we apply the shifts daily. However, if the translational shifts are more than 1.5, we will then have to reset up the patient. Once we're happy with everything and we have applied the shifts, we will then go back in the room to check the medial and lateral fields once more to ensure that the breast is still falling within the field. And before delivering the first field on the first day, we verify the fields, monitor units, angle, and direction of wedges, the X and Y jaws, and also the gantry and collimator angles. A megavoltage image is also taken through the field on the first 3 fractions when we then review it offline, as we check for the good lung coverage of not more than 0.5 centimeter, good breast contour, and also good inferior coverage. As we are looking at the treatment delivery for this patient, we are utilizing 2 different techniques. We use a forward planning IMRT for the whole breast over 3D conformal radiotherapy as it has improved dose distribution and better conformality and homogeneity index. It involves 2 directly opposing tangential beams from the medial and the lateral field. The gantry angles are optimized to match the divergence of the posterior beam to obtain a straight back border. Side beam angulation is also used to avoid the dose to the contralateral breast. The dynamic wedges involves a secondary jaw collimator moving towards a certain direction while the treatment is being delivered, and the angle is determined on the slope and the thickness of the breast to help attenuate the beam to achieve a more uniform dose distribution. As we are treating the left breast, which is in closer proximity to the heart, deep inspiration breath hold is utilized, so when the patient inhales deeply and holds, the volume of the lung increases and the heart is pushed down and away from the chest wall and the breast volume to be treated. This allows for a reduction of dose to the heart, reducing potential cardiac morbidity and its substructures compared to treatment in free breathing. A dose of 40 gray in 15 fraction of 6 mV is prescribed to the ICRU 50 reference point. This is from the START-B trial, and the rationale is that the cell survival curves of breast tumor cells, specifically are relative to normal breast tissues are similar. Therefore, when we increase the fraction size, it has minimal effect on the therapeutic ratio. The long-term follow-up of the START-B trial also displayed that some normal tissue effects, including breast shrinkage, telangiectasia, and breast edema, were less common after the 15-fraction regimen. For the following PTV dose distribution, more than 95% of the PTV received 90% of the prescribed dose, and less than 7% of PTV receive 105% or more, and there's also a global maximum of less than 110%. Some of the dose constraints for the organs at risk involves the volume of the ipsilateral lung receiving 18 gray is less than 15%, and the volume of heart receiving 13 gray is less than 10%. As we move on to the integrated boost, we utilize a volumetric modulated arc therapy, which involves two partial arcs with the starting and the ending gantry angles being the same as the base tangential fields. There's also dynamic MLCs tracking, conforming the beam to the target volume appropriately. The dose for the simultaneous integrated boost is 8 gray and 15 fractions, and there are a few advantages of this in comparison with the sequential boost of 16 gray and 8 fractions. Namely, is the radiobiological exploitation of a lower therapeutic ratio of breast cancer tumor cells by delivering a larger fractional dose to the at-risk region, as well as the logistical factors of having a shorter overall treatment length for the patients. We will then wrap this case here. We will now look at our last case with a patient in his mid-70s receiving radiotherapy to his prostate and seminal vesicles. He has adenocarcinoma of the prostate and a Gleason score of 7, which indicates a medium-grade cancer, and with his PSA levels in the range of 10 to 20 nanograms per milliliter, the cancer would be clinically stage 2, putting him in the intermediate risk. As we look at our target volumes, according to our departmental protocol, we have the clinical target volume where 48 gray would be delivered to the prostate and seminal vesicles, and 57.6 and 60 gray would be prioritized to the prostate solely. A margin is then added to this CTVs to account for systematic errors, which include daily patient setups and internal organ motion. For our patient positioning, we have the patient laid hip first supine with his arms up and away based on his chest from the treatment field. The knee fix and the prostep is indexed for his comfort to aid in reproducibility and to prevent rotation in the lower abdomen. He'll have 3 tattoos with both laterals and 1 medial, where we can then align the lateral to the lasers, and then we'll shift from the medial tattoo to our isocenter. For his internal immobilization, we will have him emptying his bladder 45 minutes before his treatment, drinking 3 cups of water consisting of 500 milliliter in 15 minutes, while we wait for another 30 minutes before we get him in. We also use microenemas for the empty bowel prep for this treatment. He has a SpaceOAR, a hydrogel spacer, placed in between his perirectal space to temporarily position the anterior rectal wall away from the prostate during treatment. A comprehensive systematic review has reported reduced toxicities, which include diarrhea, proctitis, fetal incontinence, and hemorrhoids across 7 studies, regardless of radiotherapy technique, and with long-term follow-up demonstrating improvement in urinary and bowel function and his sexual quality of life. As we look at the treatment verification for this patient, we will first ensure that he has his drinking protocol done, and similarly to our previous cases, we will also perform a 3-point ID check. And for our first day, we will align the lasers to the tattoos and also verifying our shifts applied with a ruler. And we will then check our anterior and lateral SSDs to ensure that they are falling within a centimeter tolerance. And we would then acquire our couch for it. We will also perform patient verification checks against the system, making sure that we apply any offsets that he has and that we are using the right pelvis size image for him. We then take our daily KVCBCT as it provides us with substantial soft tissue definition. Auto-match is then applied, and we have the bony match option included. After it's done, we would then perform our manual checks against the sagittal, transverse, and frontal view against the planned CT scan. When we are looking at the image, the pitch of the patient can be first quickly assessed. We ensure that his back is laid flat on the treatment couch and there is no need to reset up. And we check that there's at least 50% of the blood volume, making sure it's not falling too posteriorly or inferiorly into the PTV. And we check that there's no fecal matter or gas, that the rectum is not coming up too anteriorly into the PTV, as 50% of the rectal volume can only receive 33 gray. But the spaceOAR would also help tremendously in preventing this as well. There is a departmental 0.5 centimeter tolerance, but since we'll be daily imaging, we would still apply and record the shifts accordingly. We also would take note of any changes in the daily bladder and rectum volume regarding the scan. Before we deliver the first field, we will be verifying the field monitor units and the energy. Some things to take into consideration is that in this department, we can only apply shifts for our translational axis when we are treating our prostate and seminal vesicles. However, a 6-degree of freedom couch can potentially help further improve patient setup accuracy as we account for the errors for rotational axis. Other departments also use the bladder scanner, which utilizes ultrasound to check the bladder size before getting the patient on the bed. This can help reduce the radiation exposure from a KV-CBCT if the patient is unsure whether the bladder is full enough, and this just helps us align to the as low as reasonably practicable principle. Looking at the treatment delivery for this patient, we are utilizing volumetric modulated arc therapy with 2 full arcs, one rotating clockwise and then counterclockwise. This allowing the speed of the gantry rotation and the dynamic MLCs to modulate the beam intensity, effectively delivering radiation from an infinite number of gantry angles, which helps increase target conformality. This improved target conformality is superior to the 3D conformal radiotherapy technique, as its beams have uniform radiation intensity across the field, which makes it hard to conform to concave structures. According to RCR guidelines, this is a Category 2 patient and treatment should not be prolonged for any more than 2 days as it can be detrimental to tumor local control and overall survival. The dose prescribed is 60 gray in 20 fraction based on the CHIP trial, a phase 3 randomized study that shows the hypofractionated regimen is as effective as the conventionally fractionated regimen of 74 gray in 37 fractions. It presented no significant differences in late bowel and bladder effects. Combination of hypofractionated schedule and high precision IGRT and advanced radiotherapy technique allows for good tumor control, low level of side effects, and improved convenience over a shorter treatment period of time for patients. 6 MV energy is used for this patient, as higher energies like 10 MV is typically preferred for deeper seated pelvic abdominal lesions in larger patients due to a decrease in the integral dose and a deeper penetrating power. We would then wrap up this case. And here are my references.